Well, excellent. Thank you so much for having me here today. I'm excited to be able to talk to you guys about a subject that's near and dear to my heart, is headache treatment. Being a neurologist, probably 50% of all my new patient encounters are treating headaches, so it's exciting to tell you guys about that today. Well, it's important when we start with headaches. Headaches is such a large topic. I always find it useful to try and basically break it down in a classification system so we can kind of visualize it in our minds. And luckily, smarter people than me have already done that. The International Classification of Headache Disorder System, the second edition, has attempted to kind of take all the headaches we know and put them into kind of an organizational pattern, so it helps us kind of visualize exactly where a headache would be in this. So there's generally two types of overarching headache categories. There's primary headaches, meaning there's not a specific secondary cause, and then there's secondary headaches. I'll kind of focus on this talk on primary headaches just because we have 35 minutes and I have probably 2 hours of lecture material here if I actually went through all of it. So the primary headaches are kind of what we are on top in our initial training are tension type headaches, migraines, and cluster headaches, which are a form of trigeminal autonomic cephalgia. So we can see that migraines with or without aura, certain childhood precursors of migraines, migraine complications, problem migraines all fall under the migraine kind of category. There's tension type headaches, frequent, infrequent, chronic, trigeminal autonomic cephalgias, which include cluster headaches and a couple other rare forms of trigeminal autonomic cephalgias. There's some primary headache disorders that don't really classify into the first three that we see that we know are not secondary to a brain lesion or such. This is primary stabbing, Hypnic headaches, primary thunderclap headaches. Each one of these probably warrants 30 to 45 minutes of discussion, but once again, we're going to be limited on time what we can actually do today. And then there's the secondary headache types, which are secondary to head and neck trauma, brain tumor, infections. Once again, huge amounts of information on each one. So even psychiatric disorder can cause headaches, so it's a huge topic to cover. Well, first of all, headaches are very common. All of us as healthcare providers probably see this. Numerous patients today with headaches. Migraines alone are thought to be 12 to 16% of the US population in prevalency. Tension type headaches are even more common than that. In fact, tension type headaches and migraines are so common that probably when you see a patient with a primary headache disorder, there's a greater than 90% chance that that's what the cause of their headaches are. We'll probably spend most of our time talking about migraine headaches. Far and away, 95% of all the headaches I see in my practice are some variant of migraines, and that tends to be where I get most of my questions when treating headaches. Migraines are kind of a disorder that we're all very familiar with, but when asked to really define it, it can be kind of difficult. It's kind of like writing a paragraph on how to tie your shoe. You know how to tie your shoe, but actually if you try and define it, it can be quite difficult. So we'll take a stab at it. Here's some good definitions I've heard before trying to define exactly what a migraine headache is. One is a primary episodic headache disorder that interferes with activity and is characterized by various combinations of neurologic, GI, and autonomic symptoms. Another good one is a biologically determined episodic syndrome of heightened sensory sensitivity. How I like to think of migraines is a lot like seizures. It's something, a phenomenon in our brain that everybody has some threshold of having. Some people have a much lower threshold than others to develop this phenomenon. And what generally happens is your sensory cortex becomes sensitized to any kind of external stimuli. And when you think about that, it makes a lot of sense. So what happens when you get this horrible throbbing pain in your head is you want to avoid all light, all sound. You want to lay in a dark room and not move, avoid motion. That generally lasts for 4 to 72 hours. And if you kind of think of it that way, I found it to be an effective way of explaining it to patients. Once again, migraine is extremely common. 15% of all women, 6% of all men in the United States are estimated to have migraine headaches. Particularly menstruating women tend to have the highest prevalence of migraines. And why is that? Well, there's a clear association to estrogen. Why specifically does estrogen cause more migraines? There's a couple of theories. One is that we know that estrogen increases the body's ability to produce nitrous oxide. Nitrous oxide has been linked to migraines, so it's theorized that potentially that's the reason why. Also, we know that the uterus releases prostaglandins, and that is also thought to be possibly a reason that menstruating women have more migraines than the general population. So, migraines typically, in about 20% of the cases, will have an aura. And what is an aura? And aura basically is when your cortex becomes hypersensitized, generally in the back in the occipital region, and that hyperexcitability can produce generally positive symptoms, almost like a seizure, or sometimes negative symptoms mimicking a stroke. Classically what happens is people get hyperexcitability in the back of their occipital cortex, and then spreads across that, causing a visual hallucinations of bright lights, squiggly lines, something called scotomas. Although it doesn't have to just be visual symptoms, it could also be sensory symptoms, and very rarely weakness, dizziness. That can really make migraine aura very challenging, especially in older patients with stroke risk factors, and sometimes it's not obvious that somebody's having a stroke or a migraine aura. In fact, as patients age, they can even have migraine auras without a headache at all, called Hemiplegic Migraines. So 20% of migraines will have aura, 80% will not. Then typically comes a headache phase. That's usually 4 to 72 hours of that increased sensory sensitization, where any kind of sensory phenomena that is external tends to cause pain. Generally, it tends to be on one side of the brain, although 40%, or excuse me, one side of the head, although 40% of the time it's on both sides. So usually it's a unilateral throbbing pain that's moderate to severe in nature that any kind of physical activity exacerbates. The last 4 to 72 hours. Usually there's some nausea or vomiting accompanying it, and usually sensitivity to light and sound. Sometimes you can even get dizziness or other kind of sensations. When you actually look at how migraines are defined without aura, it's 5 lifetime attacks lasting 4 to 72 hours, with at least 2 of the following: the unilateral location on the head, throbbing nature of pain, moderate to severe in intensity, aggravated by physical activity, in addition to one of the following, either nausea or vomiting, or photo and phonophobia, basically that sensitivity to light and sound. In reality though, this definition is helpful, especially for research principles. There's lots of cases where somebody won't have all those things, but you'll just kind of get the gestalt of what they're telling you, and you'll have a good feeling that it's a migraine. Migraine with aura have a similar definition, except for they have an aura associated with them. One thing that comes up quite often in migraines is Mri abnormalities. So a patient will have severe headaches. Primary care, someone will obtain a brain MRI, and then they'll get a report back saying T2 hyperintensities could be consistent with chronic microvascular disease, atypical demyelination, prior vasculitis. So this very complicated report that's very concerning. In reality, what we notice is a very high overlap of when patients have migraines. They'll also get these benign appearing T2 hypertensities, these little white spots subcortically on the brain. There's no associated pathology with any of this. We know that they're basically linked by association, but it doesn't help us predict how severe the migraines will be. It doesn't suggest that the migraines are going to become dangerous in any kind of way. So this is just information that tends to scare patients a lot, but once we're able to look at the MRI, it's generally just kind of a benign association. It's just important to kind of be aware of this. Why do people with brain MRIs, with these T2 hyperintensities, these white spots on their brain, who have migraines, have them? It's not exactly sure. There's some theories that it may be due to some vasospasms or underlying vascular disorder, although none of these studies have actually shown any kind of increased stroke risk generally. There's a small increased stroke risk when you have migraines, but generally the MRI is not very helpful in predicting that. A lot of people have characteristic triggers in migraines. Some people do, some people don't. It's always useful to have patients basically do a headache diary and kind of determine if there is any associated triggers, but it's kind of hit or miss. One question I've been getting a lot lately in the last couple of years is the increased stroke risk when women have migraine with aura. Are they safe to use oral estrogen medications? And the simple answer is usually yes, but if you drill down in the data, this is kind of what the data tells us and how we make that decision. So generally a menstruating woman without any other medical history for stroke risk will have a pretty low risk of having a stroke. If she has a migraine with aura, statistically she probably has 2 times the normal stroke risk. If you put her on oral estrogen contraceptive medication, she gains another 2 times risk. So that means a woman with migraine with aura who you put on oral estrogen contraceptive medication has a 4-time baseline risk of a stroke. Statistically, that's still so low that probably it's not a big risk. So if you counsel a woman, she still accepts to go forward, it's probably pretty reasonable. The big increase in risk comes if a woman also smokes. If a woman also smokes or uses tobacco frequently, she has a greater than 2 times risk. So if you have all 3 of these things, migraine with aura, estrogen, oral estrogen containing medication for birth control, and she smokes, you now probably have statistically a high enough risk that you probably want to consider modifying treatment and not using oral estrogen. Another common situation is menstrual migraines. These tend to be migraines without aura. It's thought that it's probably the uterus releases prostaglandins during menstruation, and that's probably involved in the migraine without aura. What we do find is NSAIDs, particularly naproxen, are very effective at treating these type of headaches, and that's probably why. I'll kind of cover some treatment recommendations in a few minutes on this. And so let's break down migraines into kind of the two broad categories in treatment, either aborting a migraine or getting rid of an acute migraine, or preventing a migraine or giving prophylaxis. So there's two treatments, abortive and prophylaxis. I'll start with abortive. Abortive is generally when you get the migraine, what medications you take to get rid of it. And that's considered treatment successful if you give a medication within 2 hours. The migraine is essentially good enough that you can go back to normal activities. It's important to avoid a slow stage approach, meaning you want to treat sufficiently strong medications initially in order to get rid of the migraines, rather than starting with one Tylenol. That didn't work, let's do 2 Tylenol, now 2 Tylenol and a Motrin. You generally want to try and classify how severe the migraine is and use sufficiently strong medications initially. For mild to moderate pain, a lot of patients with migraines don't come to medical treatment. What they do is they'll get a mild to moderate migraine, they'll take an NSAID or Tylenol, abort the headache, and they'll do well. For those patients, a lot of times we don't see them come to care, but certainly trying any kind of NSAID like ibuprofen, naproxen, trying Tylenol, even trying caffeine is reasonable. It's very important that you recognize that if people are getting frequent migraines, they're at risk for a phenomenon called medication overuse headache. And that's generally seen when they're using simple analgesics more than 15 days a month. It's not so much how much they use at the time, it's more, do they have days where they completely use no medication? So when you're counseling patients, 15 days or more a month, they want to be on no short-acting pain meds to prevent medication overuse component from NSAIDs or Tylenol. And then if they get moderate to severe headaches, these tend to be the patients that come to medical attention. Generally, we'll find that triptans are the most effective. It's 80% effective in clinical trials. It works quite well. And it's important, if they're on triptans, furosemide, or any kind of combination medications, the risk of medication overuse headache is now higher. So typically in these patients, we need to use 10 days of treatment a month or less to prevent them from developing medication overuse headaches. Certainly patients are different. Some patients can use frequent short-acting pain meds a lot and not get medication overuse headaches. Some patients use it just a little and get it. So it's always important when you're talking to a patient, you let them know that there's just no one rule of thumb for everybody. Everybody has to be individualized. Another thing that comes up quite often is, for some reason, a few years ago, the FDA started making a very big deal about Serotonin Syndrome. So whenever, with our electronic medical records now, whenever a patient's on a medication that affects the serotonin pathway and you prescribe a triptan, you'll get this scary box that says risk of Serotonin Syndrome. And I've got a lot of calls and a lot of things where providers are asking me, like, gosh, this seems very rare, but is this a significant consideration? And the real answer is no, it's not. This is much more of a theoretical risk. Looking at clinical practices, almost no patient actually gets serotonin syndrome unless they're on incredibly high doses of psychiatric medications. So in reality, when you see this warning, you can definitely counsel a patient on a risk of a rare problem. It's just so unlikely to occur that you can feel pretty comfortable that this is just one of the many rare things that could happen, but it's unlikely to happen. Generally, triptans, all of them tend to be equally effective in aborting the migraine. There was a meta-analysis that suggested that L-triptan, which is Relpex, may be the most effective, although in clinical practice I don't see a big difference between each one. When you look at all the different types of triptan classes, generally frovatriptan, naratriptan, and amitriptan, these at the bottom, aren't used very much. These three are the least effective. Frovatriptan and naratriptan have the longest mode of action, so sometimes headache experts will use it, but it tends to require a lot of pre-authorization, so it's very expensive for patients. Amitriptan is the least effective and has the least side effects. Again, not used very much. The first four on this list tend to be used the most and almost interchangeably. They all have oral forms, but also some of them have basically disintegrated into tongue forms, a nasal injection, a subcutaneous injection. So depending on kind of the situation, a lot of nausea, they can't swallow a pill, or the migraines are horrible onset and they need relief quickly with the injection. You can kind of tailor it that way, but All of them tend to be equally effective, so there's not some specific way that you have to do it. And then other acute treatments, in addition to the triptans, you can either use in place of or in conjunction with our dopamine antagonists, such as Reglan, chlorperazine. They're both excellent anti-migraine medications because not only do they treat nausea associated with it, make the patient tired, help them initiate sleep, but they also have primary anti-migraine effects. So Reglan 10 milligrams in addition to a triptan, even if the patient doesn't have nausea, can be very effective at breaking a tough migraine. You can also add NSAIDs such as naproxen to the triptans. It tends to be effective in helping increase the triptan strength as well. Menstrual migraines in particular tend to respond very well to naproxen at 500 to 550 milligrams a day for 1 to 2 weeks. If the migraines are fresh, so a lot of times what happens is patients get 2 or 3 migraines a month, they take a triptan, it usually works, and then once every 3 to 6 months, they'll get a migraine that the triptans don't work at all. They'll call you up saying, I have this horrible migraine headache for 2 or 3 days. I've taken Tylenol, Motrin, triptan, nothing's worked. In these situations, prednisone for 5 days tends to work excellently, probably about 90% effective in breaking that refractory migraine in my experience. Typically what I'll do is do prednisone 60 milligrams the first day, 40 milligrams the next 2, and 20 milligrams the next 2. I used to do 60 milligrams for 5 days. In my experience, they all tend to be equally effective. What I have seen is when they go to the ER and get a one-time infusion of steroids, it tends to not be quite as effective as 5 days. That just is probably my personal experience, but one thing I've noticed is going to 5 days seems to really add a lot of kind of headache relief over the just once a day. One thing I notice a lot is patients using opiates or fluorescents of any kind tend to have very poor headache control. And when I'm successful completely getting them off those, the headache control tends to improve dramatically. Even using fluorescent a few times a month or opiates a few times a month has been linked with medication overuse headaches. So it's very important if a patient has horrible headaches and nothing is working, in my experience, just get them off all of these kind of complex pain meds like that. It just tends to be much more effective. Rarely patients will require opiates for headache control. I don't generally see that, but it certainly is possible. Another situation is pregnancy. So when a woman becomes pregnant, her migraines generally get better, although sometimes, unfortunately, they'll get worse. And what kind of treatment options do we have? Unfortunately, our NSAIDs and our triptans can't be used in pregnancy safely, so generally it's Tylenol with or without a narcotic like codeine. Reglan, which is a great anti-migraine medication in its own right, and then magnesium, either PO or IV, which tends to be very safe in pregnancy and ineffective in helping break migraines. A lot of times patients ask me if they really needed a triptan, could they use it in pregnancy? There is some expert opinion suggesting that Imitrex or sumatriptan may be the safest in pregnancy and may be safe in breastfeeding. However, I tend to be very safe in pregnancy, and just the safety data, again, there's too many unknowns, so I tend to not use any kind of triptans. A lot of times you're kind of forming a therapeutic alliance with the patient, and she's unfortunately having to kind of tough through some painful times with the headaches in order to protect the fetus. And it just tends to be a difficult situation to kind of get through. You're kind of just waiting until she delivers a healthy baby so you can give her stronger meds. And the second kind of arm of treating migraines is prophylaxis, or preventing the migraines. Prophylaxis is considered successful if you begin treatment and 3 months later you've had a 50% reduction in the number of migraine days you have a month. It typically requires you to take a medication every single day. It's very important when you start prophylaxis that you realize on average it's going to take 4 to 8 weeks for the medications to start working. So generally when I start prophylaxis, I'll have them come back in 6 weeks. I've seen a lot of situations where people are starting on prophylaxis and 1 to 2 weeks later they go back to their doctor and say it's horrible, it's not any better, and they'll be rapidly escalated up. Unfortunately, the problem with prophylaxis is it just takes that 4 to 8 weeks, so it's very important to kind of educate the patient that it's kind of a waiting game until it starts working. It's a long-lasting relief, but it is a bit delayed onset. So the question is, a lot of times patients ask me, I'm on a prophylaxis, am I going to be on the rest of my life? And the answer is usually no. On average, patients spend 6 to 9 months on prophylaxis. How long do you keep them on prophylaxis? So once you begin prophylaxis and you gain good control of their headaches, you want to go 6 months of that period. Once they have excellent control for 6 months, you can begin to slowly taper them and see how they respond. Again, on average, patients require 6 to 9 months of prophylaxis treatment. So which medications do we use? So there's evidence ways of grading the primary headache prophylaxis that we use. Using those evidence in my clinical experience, I've kind of developed a first, second, and third line kind of way of using the medications. And first line medications are what I find to be the most effective and have the least side effects based on their use. The medication amitriptyline works excellent as a headache prophylaxis. The problem with it is it's very sedating. Often patients will get tired when they take it at night, fall asleep, wake up the next morning and be very drowsy. And they won't really, a lot of times they don't even realize it's the medications. They're like, I feel drowsy, I have low energy, I don't know what's going on. So I found the medication nortriptyline just as effective as amitriptyline and be much less sedating. It tends to work excellent in most patients. Another medication that works very well is topiramate or Topamax, which is an anti-seizure medication. Unfortunately, we recently realized that Topamax was actually a category D medication in pregnancy with an association with cleft lip. So given that most of the patients that I treat tend to be women in childbearing ages, that's really changed my treatment a lot, where first line I'm kind of putting Topamax back, they may become pregnant and going to nortriptyline a lot more. Another excellent medication is Botox. Unfortunately, this requires training to do. It tends to be expensive, so pre-authorization is an issue. And so really this tends to be a medication that patients need to have failed 2 or 3 other agents. Very interestingly, in the state of Colorado, Medicaid will allow us to use Botox first line, which is very surprising to me. So it's funny, the Medicaid patients can actually come in with horrible headaches, get Botox a lot earlier than the other patients, just based on how pre-authorization works. But again, I would say for most people not interested in kind of getting in the weeds, if you learn to use nortriptyline well, it tends to be an excellent headache prophylaxis medication. You got to counsel patients, they can get a little bit of drowsiness at night, usually wears off in a couple weeks, dry mouth, a little lightheadedness. Sometimes it slows the conduction in your heart a little, so if you have no history of heart disease or problems, it tends to be a mild risk. You put them on 25 milligrams at bedtime, see them back in 6 weeks. If the headaches aren't substantially better or trending in a substantially better direction, you can add another 25 milligrams. And every 6 weeks go up to about 75 to 100 milligrams. I would say 90% of the time on either 25 or 50 milligrams at bedtime, if you've eliminated the short-acting medication overuse component and got them on these meds, you'll see a dramatic improvement in headache control. They almost won't believe you at first when you tell them how it's going to be, and you'll get them to trust you. You'll implement the plan. You'll see them back in 6 to 12 weeks. And they'll say, the headaches are a little better, and you'll say, let's look at your headache diary. And you're like, wow, you're down to only 1/5 as many headaches as you're getting. And they're like, you're right, doc, this has been amazing. So it's kind of funny, I see that presentation again and again, but it tends to work quite well. Other second-line medications that can be used certainly, but don't tend to work as well. The big one is beta blockers. Beta blockers are touted to be just as effective as the other first-line prophylaxis. In my experience, young people tend to not like them because it tends to decrease their energy, make them sometimes feel a little more down and such. Sometimes with men in the military in particular, they felt they had sexual side effects on it. So I don't find beta blockers like propranolol to be quite as effective. I use them a lot more when patients also have high blood pressure or some other concurrent reason. Another excellent headache medication when patients have a lot of anxiety or depression kind of interlaced with their migraines is Effexor. This is serotonin norepinephrine reuptake inhibitor. Tends to be great for both controlling depression, anxiety, and migraines at the same time. Valproate's an anti-seizure medication that tends to require a lot of monitoring, has side effects. I don't use it a lot, certainly works well if you're willing to put in all the efforts of the monitoring. Third line medications, gabapentin. Gabapentin is an extremely safe medication with a moderate anti-anxiety effect. So if you're using it for a patient that probably doesn't have bad headaches, but they have a lot of anxiety, and you get the feeling that treating their anxiety will make their headaches better, and you don't want to give a medication that could harm them in any way, tends to be great. For just treating the headaches in themselves, gabapentin tends to not work very well. Calcium channel blockers tends to not work that well. Other seizure meds, SSRIs. It's Boulder, so I get asked huge amounts of times, what supplements can I go on? I do not believe in any kind of prescription medication. They use supplements. They'll be on like 50 supplements, but they'll think statins are evil. So, which they're healthy people, I understand that. So there are some supplements that actually have some pretty good evidence at treating migraines. One with the best evidence called Butterbur actually has a linkage to rare hepatotoxicity, so liver disease. For that reason, I don't think supplements should really have much risk, so I tend to not use it very often. But there's 3 Class B medications that are very safe, and places like Pharmac or other pharmacies can often give a combination pill. So riboflavin, which is basically I think B2, feverfew, and magnesium all tend to be very safe, great supplements. You can give a patient basically independently or a combination together of riboflavin 400 milligrams a day, magnesium 300 milligrams a day, and feverfew 100 milligrams a day. Have them take that once a day for 3 months and then see how they'll do. It tends to work okay, in my experience. It tends to work nowhere close to as effective as a first-line prescription prophylaxis, but again, it tends to be an excellent thing to try if you don't want to try prescription meds, and of course it's very cheap too. It's very important, it's critically important, when I see patients with difficult to treat headaches, is to identify any comorbid problems preventing treatment response. And we all know this from treating any kind of pain disorder. It's very important to say, do you just have some kind of nerve pain issue, or is there some kind of concurrent medical problem making your nerve pain issue more difficult to treat? And again, it's very important with headaches in particular to look for medication overuse component, depression or anxiety or psychiatric disease, sleep disorder, or poor psychosocial coping skills. Sometimes we'll get patients in the emergency room, which is very difficult to treat migraine headaches. Here's a reasonable course of action to try, all very safe. It tends to be pretty effective in breaking refractory migraines. Adding hydration, magnesium, Benadryl, Toradol, and dopamine agonists, either Reglan or prochlorperazine, tends to work quite well. If that's not successful, you can go to second-line agents such as IV steroids, IV Depakote, IV Keppra. Again, once you get to the second line though, a lot of times it's very difficult to break the headache, and so you're kind of asking yourself, have I made the right diagnosis? Is this just a refractory migraine, or is there potentially a medication overuse component or a psychiatric disease preventing them from responding to first-line treatments? Again, it's very important if you admit a patient for a headache disorder, you have to come up with a decision, am I treating a refractory migraine, or am I treating a medication overuse headache, or am I treating somebody with an addiction problem? Because it's much different treatment options depending on what it is. And usually I see the patients that don't respond to migraine medications as being misdiagnosed as just having a refractory migraine when in reality they had a medication overuse component, which actually requires detoxification. So let's go to a couple cases as we are running out of time, unfortunately. So we have a 24-year-old female with greater than 10 years of 4 to 5 severe headaches per month, lasting all day when asked, if not treated. She also complains that sometimes the headaches are accompanied by a sensation that half her body becomes weak and numb for up to an hour. She says she takes Motrin 400, the headaches get better, she feels fine. She's coming in to check with you because this has been going on for so long, she wants to make sure there's not some serious problem going on. In your opinion, what do you think the best next course of action is of A, B, C, and D? And should I go on as... Excellent, and I don't know how to make the answers show up. Oh, okay. Okay, so, yep, so it's certainly reasonable to do that. So these questions, there's no right answer. You could logically conclude that if she was happy with just the Motrin 400 and that was working, and the headaches had been stable for 10 years, it's probably unlikely to be a secondary headache. So a brain MRI is probably unlikely, of course, or unlikely to show anything. Of course, it always could. Trying Imitrex, there's no problem doing that. Although if she's working well with the Motrin, doing well, reassurance is certainly a reasonable option. Again, there's not a right answer here.
So you think Hemiplegic was someone who was having weakness and numbness, and it was objectified, it would be okay to use Hemiplegic?
Well, so
particularly if they have a family history of Hemiplegic Migraines.
Yep.
Definitely not.
So the old theory that we were taught was that if you have hemiplegic migraines, meaning when you have the aura, half your body becomes weak, or you have something called a basilar migraine where you can get double vision or pass out or other symptoms of a brainstem, focal neurologic deficit. The theory was if the migraine was causing that it was because the vessels in there were constricting and getting tight. So if you gave a medication like Imitrex or any triptan, caused the vessels to be even tighter, you could precipitate a stroke from ischemia. As more and more evidence is accumulated, there's not a lot of great actual clinical evidence that this occurs, although you certainly don't want to be the first to see that. So generally, with hemiplegic migraines, the old theory was you don't use a triptan at all. What I see in clinical practice, oftentimes when people have complicated migraines, they don't have clear-cut, like, oh, I feel great, and I have a clear-cut hemiplegia. Sometimes they do. Often it's these kind of confused, sometimes I get a little weak, sometimes I'm a little dizzy, and so I tend to kind of, based on the clinical situation, kind of feel it out, but since the actual evidence doesn't show that it occurs, you know, it's kind of up in the air if that's really a phenomenon or not. But
The PDR says not to do that.
yep, absolutely. And the PDR also says you could get serotonin syndrome with it, so you're constantly trying to not let these recommendations by some government agency pinhole you in a certain area. It's the safest thing is just not to do anything, absolutely, but you know, if you're constantly trying to balance everything out in that.